If you're still trying to understand pneumothorax for your next nursing exam by memorizing bullet points on your PowerPoint slide, stop. Because in this video, well, I'm still going to give you bullet points, but you're not going to have to memorize them because I'm going to show you how to understand them instead. Ironically, when you decrease what you need to memorize, you increase your retention. You're going to finally see how to identify the most important information, how to connect the dots for yourself, and most importantly, how to start thinking like a nurse about this topic. By the way, if you're tired of overstudying and still getting borderline grades in nursing school, then drop SBSS down in the comments below, and I'm going to send you a free 10-minute overview of my entire Silver Bullet study system, which is the best way to study in nursing school. Let's make pneumothorax easy. If you haven't studied with me before, you might be a little surprised what we start with. We always start with normal information. If you skip this step, you are wasting your study time. If there's anything you have to memorize, it's going to be in step 1 of the Silver Bullet study system. In order to connect the dots, every step we ask ourselves a question. For step 1, the question is, based on what I know about normal, what do I need to know before I can begin to understand pneumothorax? And I got you covered. We need to know the basics about normal lung anatomy and physiology, right? Because we know pneumothorax is a lung problem. Specifically, we're talking about the pleura, how there's 2 layers of the lungs. There's like the lungs we normally think of, and then there's that outer protective layer with a little bit of lubricating fluid in between. And this allows the inside lungs to expand and contract inside of that pleura without friction. Can you imagine if we didn't have that lubricating fluid and it was just like dry tissue rubbing against dry tissue every time we inhaled and exhaled? That would be miserable. The other thing we need to know is about normal lung expansion. Do you know how it is that we even breathe? When the diaphragm goes down, it pulls the pleural tissue wider. That makes more space inside the lungs so that they now feel empty and the air rushes in to fill the space. And then when the diaphragm pushes back up, it squeezes all that air back out just like an accordion. If you're studying on your own, you might not realize that you also need to know a little bit about chest tubes. I'm going to show you an example in this video of how even if you don't identify this if you're studying by yourself, it's okay. There's checks and balances built into the Silver Bullet study system so that you can go back and identify this for yourself later on step 4. But for time's sake, chest tubes, I have some basics about this. I would recommend Googling it so you can see one because chances are you've never even seen a real life chest tube. And so words like closed drainage system and water seal chamber may not make any sense to you yet. But you have to know what they are in order to understand what it means by tidling or continuous bubbling. Taking an extra 5 to 10 minutes to even draw out and label your own diagram or just Google it and look at the pictures is worth your time. Do it. And that's basically all the normal stuff you need to know in order to understand pneumothorax. We can move on to step 2. Step 2, we ask the question, based on what we know about normal, what has broken or changed with pneumothorax? Since we're studying a disease process, this is going to be the pathophysiology. And with pneumothorax, we have a problem where air has entered the pleural space. Remember, normally it's just that pleural fluid there to reduce friction. Now, instead of being 2 types of tissue pushed up against each other with a little bit of fluid in between, now we've kind of got an air bubble in there. And in most cases, the air from the lungs can escape out through there. That's what it means when it says it's breaking the seal needed to maintain the lung inflation. So we can't maintain that negative pressure. Notice how we're tying things back to step 1 in order to understand the pathophysiology in step 2. This is all it takes to connect the dots. But if you didn't take the time to do your step 1 normal stuff, that's why you struggle a lot with understanding the pathophysiology. So we're going to change that now, right? I also like to add a step 2B, which is what caused it. Because there's lots of things that could potentially cause a pneumothorax to happen. But regardless of how it happens, a lot of the nursing care later, a lot of the symptoms is going to be exactly the same. So we don't want to make studying harder for ourselves than it needs to be. And yet there's going to be some slight differences in the nursing care depending on the cause as well. This is going to help us to critically think about it later when we're trying to prioritize nursing care. You can't jump directly to the nursing care and just memorize it. This is the reason that doesn't work, because there's other factors in the story that influence the nursing care later. For example, somebody who has pneumothorax because of a trauma, let's say they were in a car crash or they got stabbed, they're probably going to the ER. And we're going to have to address the injury in addition to the pneumothorax. But if you have a pneumothorax that's caused by a lung disease like COPD, Now, a client like this probably has a lot of other medical issues going on that we have to balance in addition to the pneumothorax. So the way we treat and prioritize their care is probably going to look different than the client who got the pneumothorax from trauma. But a lot of it's going to overlap too. And now we're starting to build out our strategy for how to think through situations relating to pneumothorax. This is the beginning of learning to think like a nurse while you're studying. It's why I say study like a nurse to think like a nurse. And don't forget, I have a free Silver Bullet study system overview for you so you can learn the system that I am using to teach you this right now so that you can learn to teach yourself this way too, because that's a skill you're going to need through your entire nursing career. Now that we have step 2 covered, we're going to go on to step 3, which is crystal ball predictions. And with this, we're going to ask the question, based on what I know about normal from step 1, based on what broke or changed in step 2, what do I predict is going to happen next? Now, these predictions are really important because I don't want you just to write things down based on what you remember your teacher saying. That's effectively memorization. Instead, you need to write down predictions based on what you know about normal, what's broken or changed, and what you think is going to happen next. Now, if you happen to remember something from your class that your teacher said, you can write it down only if you can explain how it connects to step 1 and 2. This is what I call the magic word because. And this is how you build your rationales and connect the dots in an achievable way. You can see here, we expect that the lung is going to collapse because we lost that negative pressure that the pleural space usually helps maintain when the diaphragm moves. No negative pressure, no lung expansion. We also see things like sudden sharp chest pain and shortness of breath because we have an injury to the lungs, okay? We just got a hole in our lungs, so yeah, it's going to hurt. These explanations don't always have to be difficult. And we have a shortness of breath because the lungs can't fully inflate anymore. If they can't fully inflate, we can't get oxygen into the lungs, the gas exchange can't take place at the alveoli, and there's not going to be enough oxygen in our blood. We're still going to get some oxygen in your blood, but not as much as we're used to. Hence, shortness of breath. The next thing we predict is decreased or even absent breath sounds on the affected side. And this is because the air's not moving in and out anymore. So you might even want to go back and add to your step 1 what normal breath sounds sound like, where you would hear them, how you would listen for them, how to use your stethoscope. Because all of that is fair game when you're being asked test questions about pneumothorax. But if the lung is collapsed, the air can't move through because there's no negative pressure, we're not going to have that airflow. We're not going to be able to hear the airflow either. Next is tracheal deviation. And this is specifically with a tension pneumothorax. So if there is the next possible complication is a tracheal deviation. So what we mean by that is the trachea here. So you have to know where the trachea is. That's step 1 normal. But the trachea gets moved to one side or the other. It's supposed to be midline, and it's not. The reason that can happen is if air is trapping in the pleural space, so the air can get in, but it can't get out, then that one lung is going to inflate like a balloon, and balloons take up space. And there's only so much space inside your rib cage. So it's going to push the rest of your lungs off to the side. And this part happens to be attached to your lungs, so that gets moved as well. Honestly, it would probably be helpful to add some additional information to a tension pneumothorax, but it's such a significant complication that you probably should do a separate silver bullet study system on it because it's even more of a medical emergency than a regular pneumothorax. And if that sounds like too much work for you, don't worry because all the step 1 information is the same. So you just copy that over to another silver bullet study system. The step 2 is almost exactly the same, and a lot of the step 3s are going to be the same as well. So it's really not that much work. It's almost just like you're zooming in on one specific way a pneumothorax can play out. And since tension pneumothoraxes do tend to be tested a lot in nursing school, it's probably worth your time to do that. We're also going to expect to see tachypnea and hypoxia because the surface area for gas exchange reduces the oxygen levels. So tachypnea is fast breathing, so above 20 breaths per minute, which if you don't know the normal range for breathing, that's something you can go back to add to step 1. Remember how I said there's lots of checks and balances in this process, so you don't have to stress out the first time you do your step 1. You'll have opportunities to go back and add what you need later. And hypoxia is that the tissue is not getting enough oxygen, and we already explained why that is. It's because the oxygen is not transferring to the blood in the alveoli because it can't get there. We've lost the negative pressure that sucks the air in. Now we're on to step 4. Now I'm just going to bring step 4 up. This is where most nursing students try to jump in their studying, but you can see this is actually the last thing we do. That's why I call it finally nursing care. And the question we ask in step 4 is, what do I need to know about normal? what has broken or changed, what happened as a result, and now what are we going to do about it? And this is both nursing and medical care. Because as a nurse, even if it's outside your scope of practice, you still need to be aware of it. Now, there's lots of different ways you can organize this information in step 4 so that you don't get spaghetti brain. I cover a lot of different strategies for how to organize your silver bullet study system in my extended course inside my Study Like a Nurse tutoring membership. So this represents one way to do it. So some immediate interventions is we want to administer oxygen. Notice we're still using the magic word because we need to understand why. We need to connect these interventions to the previous steps. This is how you eliminate memorization and you develop that think like a nurse skill. If we can give more oxygen, we're maximizing the oxygen that does get transferred into our lungs while we have this pneumothorax going on. We're going to expect a chest tube insertion, so we need to do the things, we need to prepare any tools and supplies and things like that. So maybe we want to go back into step 1 and add some additional information about chest tubes and what is the nursing role, if anything, and what kind of preparation would we expect for that procedure. But the reason we use a chest tube is because this is how we get the air out of the pleural space and put a temporary seal over it so that we can restore that negative pressure environment and the lungs can go back to functioning as intended. And don't forget the obvious assessments. If we expect that the lungs are not going to be functioning properly, we should be assessing how the lungs are functioning. What are the breaths per minute? What are the breath sounds? Do we hear them everywhere or are they missing? Remember, those were the things that we were predicting in step 3 would happen for the pneumothorax. So in step 4, we simply want to go back and say, are they really happening in this particular client? And then you can see for ongoing care, a lot of it has to do with the chest tube system. And this is another very common testing area when it comes to pneumothorax. It's a little bit of a personal decision whether you want to put this information in step 4 or step 3. You could see that what made sense to my brain was to put some of the normal basic information about the chest tube system in step 1, because that's normal. It's true no matter what we're using a chest tube for. But here in step 4, I'm taking that basic information from step 1 about the chest tube system and applying it specifically to the pneumothorax situation. For example, with intermittent bubbling, we expect to see that when there's a pneumothorax because there is a hole in the lungs. There is air escaping out of the chest tube, bubbling up through the water. But it's only going to do that when you are exhaling or coughing, because when those lungs are being squeezed like an accordion, that's when the air is going to leak out of the hole that's not supposed to be there. And now it's going to travel through the chest tube and out through the water seal. And what happens when air goes through water? It makes bubbles. But when you inhale, no air is being pushed out, so you should have no bubbles. Intermittent means it comes and it goes. Now, one of the ways we can tell that the pneumothorax is healing is because the bubbling decreases and eventually stops. If there's no more hole in the lungs, there's no more air escaping out of the lungs. And that means there's no air to go through the chest tube and bubble up through the water seal. But bubbling is not always normal. If you see continuous bubbling, this indicates a possible air leak that's not coming from your lungs. Because remember, the lungs should only cause bubbling when you're exhaling or coughing. And coughing is really just forceful exhaling, right? So if we see continuous bubbling in a test question, that's a signal that something is wrong and we need to intervene. And we often do that by troubleshooting the chest tube setup to see if there's a leak somewhere in the tubing. And then don't forget about patient education. You could go on forever for this. Don't obsess over it. A big part of nursing school is learning to trust your brain. We teach clients to report any sudden symptoms or changes in symptoms, anything out of the ordinary that might indicate a worsening problem. And because the pneumothorax has a lot to do with pressure, we would avoid things that would increase the pressure, so like strenuous activity or air travel, because those can change the pressure, which even if the pneumothorax is healing, could cause it to bust open again. And nobody wants that. Remember, I want to teach you to study this way for yourself. If you're ready for that too, drop SBSS in the comments and I will send you a link to teach you how to do the Silver Bullet study system for free. If you're ready to test yourself on pneumothorax with some NCLEX style questions, then head on over to that video over there. Otherwise, this video here is the one for you. See you there and good luck on your nursing school journey.